Good morning. My name is Wendy Rantang, and in this presentation, we will examine the regulatory barriers preventing APRNs from practicing to the full extent of their training and what can be done about it. Our primary source is from Barbara Safriet's landmark 2011 paper from the IOM's Future of Nursing report. This presentation covers 8 focused topics across 20 slides, 2 regulatory provisions that restrict APRN practice, 3 barriers that prevent reform, Oregon's model of full practice authority, California's AB 890, and the implications for our future practice. So let's begin. We begin with Section 1, the 2 core regulatory provisions that Safriet identifies as the foundation of the problem facing APRNs across the country. Provision 1 is state-based scope of practice limitations. Safriet illustrates this powerfully with her State A versus State B example. An APN with a master's degree and national certification can practice fully and independently in one state, whether it's prescribing, diagnosing, admitting patients, and the moment he or she crosses the state line, those same abilities become legally prohibited. Louisiana's Board of Medicine ruled that not even a trained nurse anesthetist, directed by a physician, could treat chronic pain. As shown on this slide, the restrictions range from prohibitions on independent prescribing to requirements for physician supervision, to the inability to certify patients for hospice or sign basic disability forms. Safriet's point is clear. Competence does not change at the border. Only the law does. Safriet names this the can versus may gap, and this slide captures it perfectly. Physicians hold what the profession itself calls a GUMP license, which is General Undifferentiated Medical Practice. It authorizes virtually any health intervention. When a physician gains a new skill, they simply use it. No legislative provision needed. APRNs are in the opposite position. Their practice acts are carved out from medicine's universal claim, so their clinical competence routinely runs years ahead of the legal authority. Every new skill may require a costly return to the state legislature. This is, as Safriet argues, a profound waste of professional assets. Provision 2 is what Safriet calls economic invisibility. APRNs are paid only 65 to 85% of the physician rate for identical services under Medicare and Medicaid. Under Incident to Billing, APN services are submitted under the supervising physician's NPI number, making it impossible to track the volume, quality, or value of APRN care in national data. Because nursing services appear as a cost, not a revenue line, APNs are excluded from the policy conversations that determine how care is valued and paid for. This invisibility is self-reinforcing. No data means no voice, and no voice means no change. Section 2 examines the 3 root causes that make removing this restriction so difficult, even when the evidence for reform is overwhelming. Barrier 1 is historical and structural. By the early 1900s, every state had adopted a Medical Practice Act claiming the entire human condition as medicine's exclusive domain. This established the legal infrastructure APNs still fight against today. Each legislative battle to expand APRN authority is costly, state-specific, and politically perilous. And when the most restrictive state becomes the national benchmark for payment, Safriet describes a race to the bottom, where even progressive states face pressure to restrict more. Legislative inertia means Reform requires extraordinary political will that is difficult to sustain. Barrier 2 is the general public's lack of awareness. Safriet calls it the most amorphous barrier, but also one of the most powerful. APRNs have only been formally recognized for 40 to 50 years. Laws requiring a physician's name on APN prescriptions and advertising that says only your doctor can prescribe actively reinforce the misperception that APRNs are somehow lesser providers. The consequence is that patients who do not know what APRNs can offer cannot advocate for access to them. Without a vocal public constituency, legislative reform has no political engine. Barrier 3 is organized opposition from medical associations. The AMA, the ASA, and the AAP all hold official policies opposing independent APRN practice and direct reimbursement. In 2005, the AMA formed the Scope of Practice Partnership specifically to concentrate resources against APRN scope expansion. But as the evidence panel on this slide shows, no study has found that restrictive scope of practice laws produce better patient outcomes. Trzynski and Udalova confirmed in 2018 that deregulation increases utilization without harming quality. This opposition is about market competition, not patient safety. Section 3 asks, what does success actually look like? We turn to Oregon, one of the earliest and most compelling models of full practice authority in the United States. Oregon granted NPs independent practice authority in 1981 and has continuously strengthened that model. Its 5 defining tenets are no physician supervision requirement, full independent prescriptive authority including Schedule 2 through 5 controlled substances, direct and equal Medicaid reimbursement, the right for patients to designate an NP as their primary care provider, and critically, the Board of Nursing as the sole regulator. No joint medical board authority required. This last point directly eliminates the structural barrier Safriet identifies as central to reform failure elsewhere. The results in Oregon are evidence-based and compelling. NPs were able to establish independent practices in rural and frontier areas where physician practices were absent, directly expanding access. Trzynski and Udalova found no evidence of harm to quality. In fact, utilization increased. The RAND Corporation confirmed that NP supply is consistently higher in states with expansive scope of practice regulations, and NPs deliver care across a broad range of diagnoses at equivalent quality and lower cost. Oregon proves the model works, and Safriet argues its success is the best evidence that restrictions elsewhere are irrational. Section 4 examines California's response. Assembly Bill 890, signed in October 2020, represents real progress, but it is important to understand both what it achieves and where significant gaps remain. AB 890 creates 4 meaningful gains. First, a pathway to independent practice for NPs with 3 or more years and 4,600 hours of post-licensure experience in qualifying settings. Second, those settings include federally qualified health centers and rural health clinics in physician shortage areas. Third, experienced NPs may prescribe independently, including controlled substances. And fourth, NP-led practices in underserved communities become eligible for state funding. These are real steps, particularly for the Californians who need care the most. However, 5 significant barriers remain. The 3-year supervised experience period still requires physician oversight, perpetuating the dependency model Safriet critiques. Independent practice applies only in designated shortage areas, excluding urban NPs in private practice, who represent the majority of California NPs. The California Medical Board retains joint authority over prescriptive practice. Private insurance are not required to pay at parity, so economic invisibility persists. And APN still cannot independently admit patients to California hospitals. AB 890 is progress, but both core regulatory provisions remain substantially intact for most California APRNs. In our final section, we identify the intervention best supported by evidence and discuss what all of this means for us as future APRNs. The most powerful intervention Safriet proposes is adjusting the Medicaid federal managed formula, increasing it by 0.5% for states that adopt the preferred scope of practice framework and decreasing it by 0.5% for those that do not. This works because states respond to funding. Medicaid expansion under the ACA proved that conclusively. This approach reframes reform as a fiscal issue rather than a turf battle, rewards states like Oregon that have already led, creates a consistent national floor without unconstitutional mandates, and ties funding to both provisions together, scope of practice and reimbursement parity. RAND estimated $4.2 to $8.4 billion in potential savings in Massachusetts alone over 10 years. The economic case is undeniable. For future APRNs, this is not abstract policy. It defines your daily professional reality. Know your state's scope of practice laws before you practice. The can versus may gap can expose you to legal risk even while you are delivering excellent care. Engage with professional organizations like the AANP and ANA. The 27 states with FPA got there because APRN showed up and advocated. Understand reimbursement. Direct billing gives you professional and economic independence. Where collaborative agreements are the law, use them strategically while working to change them. And also, document your outcomes. Every quality data point builds the evidence base that counters organized opposition. In conclusion, Safriet wrote that the flaws in our regulatory framework rob us as a nation of the full range of care our providers are capable of offering. That remains true today. 2 provisions, scope of practice limits and reimbursement inequity, constrain APRN deployment. 3 barriers sustain them. Oregon proves reform works. AB 890 shows it is politically possible even in resistant states. Federal fiscal incentives are the most powerful lever for national change, and your role as future APRNs is to be informed, to advocate, to bill correctly, and to contribute to the evidence. The gap between can and may is a policy choice, and it is your mission to close it. This final slide lists all of the references in the APA 7th edition format. And this concludes my presentation. Have a wonderful day.